like to welcome Dr. David Weiss, a physician specializing in musculoskeletal and spine care with focus on non-surgical and interventional pain management. His clinical work emphasizes innovative and patient-centered approaches to treating chronic pain and spinal disorders. Dr. Weiss has been involved in research and clinical education aimed at improving outcomes of pain management, pain medicine, and rehabilitation. Welcome to the podium.
What I'm going to try and talk to you about today is, as you get older, unfortunately, the younger members, they're really going to get involved in this yet. Unfortunately, your surgery may not or stay with you, and you may want to continue with the field of orthopedics like I do. And so it becomes apparent, well, what can I do? What avenue can I go to stay active in the field of orthopedics or neurosurgery for that matter? And one of the fields is performing independent medical evaluations. So what I'm going to try and teach you today, or get you a formulation of, is what is the orthopedic approach to the science of performing an independent medical evaluation. I'm sure that everyone here in this room at one time or another has performed an IME. The question is to put out a quality IME that is bulletproof, that you don't have to worry about some nasty attorney or some nasty judge going after you while you're on the witness stand, to prevent that, and try and give you an outline to be within the objectivity of performing the IME. So the first question is, what is the IME? So an independent medical evaluation is an examination performed by a physician in his specialty where there is no physician-patient relationship established. And that's an important point, because sometimes the insurance carrier will send to you an IME where you were treating, or actually the operative surgeon involved. And in some states, that's a violation of the board in that state, because the physician is now rendering an opinion that may be adverse to the patient that he treated without giving him a oral or written explanation of what he is doing. The other thing, it's against the American Academy of Orthopedic Surgeons committee, the sanction committee on this as well. You cannot render an IME on a patient that you are the treating physician, or you shouldn't. You shouldn't. So it's an examination conducted by the doctor in his field of specialty, where there is no physician-patient relationship established. So, what are the key components of the high-quality IME? Well, you need to take a good review of the medical records. Now, in some cases, I have 2 board-certified orthopedic physicians that work within my group. So I'll have my PAs go through the medical records and give me an intake appraisal of what's going on with the patient. So you need a good history of the presenting illness or injury. How did this accident happen, or how did this happen? If we're looking at an occupational issue, we look at aspects called pace, time, duration. You don't want to hear that the patient went to work for this particular company doing repetitive use for 2 weeks, and now they're filing a claim petition for bilateral carpal tunnel syndrome. That doesn't work. I don't want to hear that. So what are the complaints? What's affecting your activities of daily living on a day-to-day basis? The next aspect is, what do you find on your own clinical examination? You're going to have plenty of medical records from the treating doctor, from maybe a second opinion doctor before you got there. But what are you finding? And then, as I said, the record review. And in my particular case, I'll review at least 20 sets of MRIs in a week. different, it's my standard of care in my own orthopedic practice as well as in my IME practice, and I look at all films myself. I don't trust the neuroradiologist, but I don't trust the neuroradiologist. So I look at my own films at all times. And then the conclusion of what you're looking at. So that becomes the next issue. Now, there are some practice pearls to this. You have to obtain the exact mechanism of injury for figuring out how did this happen. Patient may have slipped and fell. Okay, they fell on their back. All of a sudden, it's not just the low back. It's the low back. It's the neck. It's the hip. It's the knee. It's the ankle if they have a smart enough attorney to put it in. So you have to relate what is part of this injury, what isn't part of this injury. If it's an occupational disease or what we call repetitive trauma disorder, you have to get a detailed history that talks about time, pace, what are the requirements of the lifting, can these causes then cause this patient's issues? Can they aggravate a degenerative condition? Can they cause an acute condition, a micro-trauma technique? What is that? So that's why we look at all the musculoskeletal factors. Toxicology issues, we really as orthopods or even in neurosurgeons, we don't get involved too much on the toxicology, and we shouldn't, because that's really out of our range. Document treatment outcomes, both positive and negative. Okay, you have all these records in front of you now. What is it showing you? Does it show that the patient came to therapy, didn't go to therapy? Was the treating neurosurgeon, they said, you know what, you're going to need some interventional pain management. Oh, I'm not doing that. I'm not doing that. So you want to record what are the treatment, and then document inconsistencies between the claimant's history and the records provided. Key issue. You have to be a detective. When you're doing an IME, you're seeing the patient one time. Your job is to investigate. That's your job. Your job is to investigate the history, investigate clinical outcomes, and investigate your own orthopedic or neurosurgical hands-on examination for consistencies and inconsistencies. So that's what, and in some of the aspects, I also have the honor of functioning as a federal referee since April of 23 for the U.S. Department of Labor in orthopedics. And in the federal system, instead of using attorneys or judges, the board-certified orthopedic surgeon is elevated to the position of handling cases where there's discrepancies between the second opinion doctor and the treating doctor. So the federal referee issues the opinion, and the nice thing about it is I can't be appealed. So once I set I'm the finder in chief. So once I set to order and write my opinion to the feds, that's it. So so we also get into return to work. Can this person go back to work as a mail carrier? Yes or no? Now sometimes you have to take into account how long has the patient been out of work. If they've been out of work 10 years, you're not going to send this person back as a letter carrier who's now 65 or 70 years old. It's not going to work. But you might want to say, you might think, you know what, he could do some sedentary work. So you're right, you fill out your forms and you say, I think he can do sedentary work. I think he can work 20 hours, 3 months, does okay, move him up to 40 hours a week. I mean, I had one person they sent to me, the initial injury was in 1978. So you can imagine we had to go through boxes of records on this guy. And the treating orthopod said, well, now the patient has herniated discs. They're directly from the injury in 1978. And what we had here was a guy who was diagnosed initially with a strain and sprain. You got to remember, it was before MRIs in 78, who somehow got this thing through, got his Social Security exam through, and now he has a doctor says, oh, well, now you need interventional pain management. You're 72 and a half years old. I did an MRI last week, and now, based upon the MRI, you have 2 herniated discs directly attributable to the 1978 occurrence. So that didn't go over very well, you know. I'm not here to be anti, I'm not here to be pro, I'm trying to stay in the middle. We all have biases in this world. Some of us make good defense doctors, some of us make good petitioner doctors. But you gotta kick your biases aside and just look down on what records and your own exam and common sense tells you. Now, one of the things we use, and I had a question for the, remember yesterday, we had a question about outcome measurements. You remember one of the medical students said, oh, we ask them 3 questions. How are you doing? How are you feeling? Well, that's not good enough. What you're supposed to do, and this came out of the AMA guides in 2000, the 6th edition, 2008, is called the Patient-Reported Outcome Measurement Instrumentation Systems, or what we call PROMA studies. So in other words, the patient comes into your office, let's say you're the treating doctor in this case, and you say, how are you doing? How's everything going? The patient says, oh, I'm okay. So the doctor writes, patient extremely happy with outcome, da-da-da-da-da-da-da. What he didn't ask him is, are you doing everything around the house you did before? Are you back to working the same functions? So we came out with these, what we call the PROMA studies. And so one is the DASH, the disability arm, shoulder, hand. The other is the lower extremity study. We look for knees and hips. And now we've even fine-tuned it even better to just the knees, just the hips. And then the last part of it, we use the stiff people that have had post-op surgery or fusions. We use a stiff back study as well. Now, the other big question, and I'm sure you've all faced this from time to time, is does trauma aggravate degenerative joint disease or disc disease? So, and how many here believe that trauma can affect somebody that has an asymptomatic, quiescent degenerative condition? You guys should be petitioner doctors then. I can tell you that. In the 5th edition, you have to have a real adverse effect that alters the course of progression of the pre-existing degenerative disc problem. In the 6th edition, it starts an increase in degenerative joint disease and disc disease symptom signs or impairment that never returned. And the key here is that it never returned to the baseline. So what you have, and you'll hear people use the word exacerbation. Okay, exacerbation means you have an injury, here you are at this injury, you go up, you never come back to that baseline. In an aggravation, you never come back to baseline. In an exacerbation, you come back to the baseline. You where you were before the day of the accident. You return to that level. So that's called an exacerbation, not to be confused. The aggravation means you never return to baseline. Another question you're going to get into is apportionment. Now, the book I use, and this is the book all the Fed referees use, is the Injury Causation Guidelines by Melhorn. 2nd edition was published in 2014. When to apportion, when not to apportion. Because sometimes a carrier may ask you, or even an attorney will ask you, well, what percent is directly from this injury, what percent is from prior or subsequent. So when a compensable injury or exposure causes a new condition, there is no apportionment or subsequent evaluation and treatment. So that's pretty self-standing. Guy never had an injury with his back. He has the injury at work. He's got a herniated disc. You look through all the medical records, you can't find anything. Apportionment is not warranted when a pre-existing asymptomatic, untreated condition is rendered symptomatic and now requires evaluation and treatment. Okay. So what we're saying here is, you do an x-ray of the knee, you do an x-ray of the neck, you maybe get an MRI of the neck, an MRI of the knee, and lo and behold, the guy is 40 years old, and according to Bowden, who published his series in the Journal of Bone and Joint Surgery on asymptomatic conditions, he has degenerative disc disease, or he has osteophytic changes that's seen on the MRI. So now, that wasn't caused by the accident, because the MRI was done 3 to 6 weeks later. It's impossible that you get degenerative disc disease in 3 to 6 weeks. just doesn't happen. So, but the condition was asymptomatic and untreated. In other words, Mr. Smith says, well, doctor, I never treated for my low back before this. Okay. And you look at all the medical records because you're a detective, and remember, you're solving a puzzle. When you do an IME, you solve a puzzle. Like any puzzle, there's multiple parts. There's the history, there's the actual examination, review of medical records, and your personal review of the films. So, and then the last one, the same is usually true with respect to a pre-existing symptomatic but untreated condition, if not for worsening as a result of the compensable injury or exposure. So these are decisions that the referee has to make on the patient, because you get into issues where the treating orthopod or neurosurgeon says, this patient needs spinal surgery, or this patient needs a total knee replacement. Well, the carrier does not want to pay for a total knee replacement, no more than they want to pay for a 2-level fusion that a good neurosurgeon may be recommending. They don't want to pay for that, especially if there's pre-existing. So what you have to find and what you have to determine is, would this degenerative disc disease had progressed to the level that you were going to need to do a 2-level fusion, or had progressed to the level that you were going to have to do a total knee replacement? And that's a big question you have to answer. Now, if it's an asymptomatic patient and I have no history of having viscosupplementation therapy to the knee, or Synvisc injections, or cortisone injections, I'll have to go that this was caused by the accident. The same thing, if the neurosurgeon or spine surgeon says, this guy was asymptomatic, never any documented radiculopathy, you would have to be able to say to yourself, well, the guy woke up one morning out of the clear blue sky with 2-level herniated disc and radiculopathy. What's more, so the big question becomes, what's more likely than not? And that's the decision you have to make a decision on. What's more likely than not in your mind? So, a couple of things I want to do. Yeah. Another issue is that I come across is, can an opposite lower limb cause a problem with the unaffected limb? And by that I mean, you have a knee injury, now all of a sudden you've got a claim petition in front of you that says, well, the knee injury caused the opposite knee now to be affected. Or the patient has a low back issue and now complains about the hip, or vice versa. Can the hip cause a low back? There was a study done by Hall back in the 90s. He looked at this and found that there's no clear evidence to suggest that an injury to one lower extremity would have any significant impact on the opposite uninjured limb unless the injury resulted in major muscle, nerve damage, or complete paralysis of the damaged leg, or shortening of the injured lower extremity resulting from a leg-limb discrepancy of 4 to 5 centimeters. Now, this sounds like a hard statement, but in orthopedics, if somebody injures their knee, the first thing they're going to do is protect the opposite knee by shortening their stance. Well, if they shorten their stance, how in the world are they going to develop opposite leg issues? I know in spine recently we've been talking about, or at least I've been seeing it in the literature now, what we call a hip-spine syndrome. And we're seeing patients now that have had fusions at the L5-S1 level within a period of time develop hip issues. Maybe the guy had underlying asymptomatic degenerative joint disease of the hip, but because of the imbalance from the fusion, has now developed a full-blown degenerative joint disease of the hip. So the name became, and I think you're probably more aware of this than I am, of what we call the hip-spine syndrome, because of what we've created in this particular injury.
But we do see quite a lot of sacroiliac joint dysfunction with multi-level fusion surgery.
Yes, we
Which
do.
has become, yeah, which confuses with the
Hip spine syndrome. All right, so here it is. Here's your fusion of L5S1. Here's your hip spine syndrome. Here, over here, is your SI joint dysfunction. Now, I've seen the dysfunction go as far as pain management, radiofrequency ablation procedures, and then fusion. I've seen 10 patients this year that have had fusions to the SI joint, and I've even seen bilat fusions to the SI joints now. I mean, and for me, I have to put a number on the case sometimes, and the impairment just goes off the wall because I got a low back fusion, and now I got to work with SI joint fusions. So I have to separate it, like you're talking about, separate them out, and then use a combined table to figure out what the hell the number is here, figure out what the number is going to be in the impairment. So, yeah, and you're right, you're absolutely right. In terms of disclosure, there's been no financial interest or personal relationship. I have no personal relationship with the AMA, although I did work on one session as their public advocate for the new guidelines. But other than that, there's no financial disclosures here. Do you want me to start? I'll take questions and see if you got time. I'll start the second one.
No, I mean, I think this opposite limb causation is a very relevant question because I think to Wayne's point too, in the hip spine, the adjacent level syndrome too, adjacent to the fusion. We deal with that a lot. Somebody who had a car accident 10 years ago had a fusion at the time, and then is coming now with fusion. He had an L5S1, and now he has L45 disc herniation or degeneration. And it is to some extent because of the fusion. I mean, we all know that it does induce more stress to the adjacent level. So then is that a portion to the original injury, or is that a natural history? Fusion? That is always a tricky question.
If you're talking about adjacent segmental disc disease, I include it as part of the issue because the patient didn't have a problem at L4-5, gets the fusion at L5-S1, and then comes back to you within 2 to 3 years, and now you look at the new films and there's a collapse at L4-5, there's loss of signal at 4-5, and there's osteophytes and whatever other good things you can get down there. And now he's in pain, and you do your initial maybe a CAT scan, and you see that your fusion is stable. There's nothing wrong, there's no backing out of the screws, everything looks good, there's no fractured screws or anything like that. And then you look at the MRI now, and you see that 4-5 is a potential player. You send them out for some pain management, it doesn't work now, they're back in your office, you got to make a decision. The next decision that I would have to make as the evaluator is, do I put the 4-5 into the case? And the answer would be yes, I do. Yes, I do. If that wasn't there initially, he's probably one of the 35 to 40% in the literature that unfortunately has developed adjacent segmental disease. Go ahead.
This is really interesting. How many, this sounds stupid, how many guys are like you out there that can hunt this down? Because I would think your field of this would entail a lot, yet how many cases do you see for this, and are there hundreds of folks that are investigators like you?
Our group does 500 IMEs a month. Now, my group, we have, one of my guys is now 82 years old, trauma surgeon. We have another one who was a fellowship trained hand surgeon out of New York, who's 80 now. We just went on a youth kick, and we hired a guy who's 67 years old. So when the attorney said, "Can you have younger guys?" I said, "Yeah, we just went on a youth kick." And now the group has expanded that. We have the chief of pulmonary medicine at one of the hospitals who came with the group now, and he's doing pulmonary IME work. We have a neuroradiologist in our group. We have a neurosurgeon from Princeton Brain and Spine who's doing need for treatments, because I said, The spine is getting so complicated. It's, when we go in to testify, they say, well, doctor, you're trained in general orthopedics, is that correct? You are not a spine, no, you are not a neuro. So I brought in a neurosurgeon now to bring it out. We also have a fellowship-trained neuroradiologist from Penn who looks at the films on second reads, because we look at the film sometimes and I'll say, geez, what was this radiologist thinking? I said, here's a herniated disc, here's the bottle cap. You can't miss the bottle cap. I've been trained by her to look for bottle caps in life now. That's what I look for. So we've expanded out our group. But we do like on a normal month, we'll do between 400 and 500 IMEs in a month. So we're experts at this field, but before we were experts at this field, we were doing orthopedics, we were doing neurosurgery, we were doing spine surgery, and we just moved on in life, you know? I mean, hate to say it, but in 3 years I'm going to hit 80. So, but the nice thing about this is you can keep doing this. The oldest doctor who did this for the feds that I had to review his work hit 100 years old and got the McGinnis. He graduated medical school in 1947, and he just died at 103 because he cursed himself. They went back and they did a whole day of his life at 100. Then they interviewed him at 102, and he says, I don't think I'm going to die. He says, I really believe I'm going to live forever. Within a year, he died. So that was a bad thing to say about him, but he was doing a vows up until he died. So, I mean, there is a way that you can have satisfaction doing this work, as long as you keep in mind that you are here to solve a puzzle. And then at the end, like any puzzle, you solve what's being asked for you. If you can do that, you can have a good life. The average IME, that's the average. Some are, you know, like in New Jersey, we're fee scheduled on workers' comp to $1,000 to do a work comp eval and put a number on the case. But like in the feds, my evals go, and these are the Fed numbers, 2,500 all the way up to a complex case like I had with 2 boxes to $8,000 per evaluation. And you're not in court, because you are the federal referee. You've given the opinion that that's it. Nobody, you'd have to do something egregious in your IME to be under the microscope and to be appealed by the appellate court. The federal appellate court would have to then appeal it. But you could be doing this for the rest of your life if you want to. And that doesn't include court appearances, which is over. If you're a neurosurgeon, we hate them. The neurosurgeons get anywhere from $5,000 to $10,000 now to appear in court. Orthopods, not so much. We get 3 to 5. But because they're neurosurgeons, they get $5,000 to $10,000. I don't begrudge them, because that's what the market is.
But I think as time passes, in maybe like a year or two, all these data sets can be fed into the AI, and it can generate the whole report within a short time, and you know, the IMEs will become an obsolete thing.
It won't. It never will, for one reason. There's that third part of the puzzle that the AI can't do, and that's the physician's hand-on examination. The AI can't do in a knee, a McMurray's, aptly grind, a telofemoral compression test, can't do it. Can't do rotator cuff drop test. A nurse can't do sitting root, straight leg raising, can't do motor and sensory. I mean, on my exam sensory, I do Sens-Weinstein on all my orthopedic cases that are spine. I do Sens-Weinstein on all of them. And because it's the poor man's EMG. I mean, they all can't get EMGs, but here you go and you get the Sens-Weinstein. It's not hard to learn how to do. I know there's all these, but even my guys that were, well, my hand surgeon was easy. He understood it right from the get-go. But my orthopods that do general orthopedics, they were scopers. They didn't even know what the hell we were talking about, 2-point discriminations. But we taught them, and they all do them now. It's part of our protocol. But that's what you do. So the AI, we use AI sometimes. When we're looking at these postal carriers, and what they have to do is carry a 75-pound bag up the steps. How many steps a day do they do? In and out of the Jeep, how many times a day do they go out of the Jeep? We feed that into the AI. Can this cause an aggravation of a degenerative disc disease? And the answer to the question is yeah, it can. On the AI, it's referenced, they give you the references for it. So talking about impairment, how do we get into the second part?
Continue then.
He's got 2 talks.
So we do
It's
have
not
to-
listed. It's not listed there.
Am I over time?
No, you got 2 talks basically.
Okay. Let me.
I don't know if they have coffee breaks with the other one. Do they have, they can switch
Okay.
sometime?
As of 2024, the AMA took the 6 guidelines. How many of you were familiar with the AMA guides?
A little,
A little bit.
a little.
Okay, so the AMA is recognized in about 47 states with their guidelines to do impairment rating. 7 states have opted out of the AMA completely. New Jersey, where I practice, is one of them. Now, Pennsylvania uses the AMA in workers' comp. New Jersey doesn't. We use our own numbers. New York uses their own type of numbers. Florida uses their own type of numbers. But then what happened is a group got together, and I'm not here to disparage or anything, and decided they were going to rewrite it and make it digital. Remember yesterday one of the med students talked about generation this stuff. So no more book. It's all going to be digital now. And so this is the new AMA format. In the old book, we had a static printed book. Now it's online. You have to pay $279 for it, and then every year you have to pay another $279 to update it. But the benefit is it's continual updates, real-time improvements. In the previous guides, when we had spine pathology, we'd have to go to peripheral nerve root injuries to make a number. We'd have to, if radiculopathy counts in the AMA, so you have to use, so we would have to go to Sens-Weinstein, 2-point discrimination testing, to go over the nerve roots, the 4, 5, S1, L2, 3, whatever. So that was different. This one, you have guided workflow and models, clickable models. The other was manual chapters. You'd have to go through the manual chapters. Now, in the old book, we had diagnosis-based impairments, and we had range of motion models. So the doctor would compute the diagnoses, which was on the grid, versus a loss of range of motion except for spine. In the 6th edition, they took range of motion out of the spinal pathology. And the reason is that there were studies that showed that people can have excellent range of motion in their spines in both the neck and low back, but yet have terrible, terrible problems with their low back. They also found that people could have significant restrictions in range of motion, but have no problems with their low back. So as of the 6th edition, which was published in 2008, we did range of motion, we did it ×3, but it didn't count toward any type of assessment or impairment. So now what they did is they put and so what we had in the AMA model, the old model, we had functional history, physical exam, and clinical studies. And so we had these formulas. We would minus what the grid number would be, minus the functional history, minus the PE, minus the CS, and then at the end you get a number, and that would decide whether you moved your number up or down two groups. But you never can move out of a grid. In the AMA system, once the doctor put it into a grid, he couldn't move out of the grid. He had like 15 to 19. The center point would be the 17, and depending upon what these formulas, you could either move up to or move down to. In the new one, what you do is now you find your grid number. Let's say it's a partial rotator cuff tear. you go onto the computer, you find that maybe 17215 is partial rotator cuff tear. Then you go to your SIEs, or specific individual elements, which are parts of the history, parts of the physical exam, parts of the studies. So in the new issues, what we're saying here is now range of motion is incorporated into the SIEs, versus before you could decide, the examiner could say, well, the range of motion of the shoulder is really worse. He's got 90 degrees here, 90 here. He's got crossover of 55. His posterior reach is down. His backward extension is down. So the range of motion model might be greater than the grid model for the rotator cuff repair. So therefore, you would go with the range of motion deficit. You would get that. Radiculopathy is rated under the spine chapter now. We use two numbers. We have a 0.6 for the upper extremity, 0.4 lower extremity impairment, versus the AMA. We use the newsletter on the peripheral nerves to give an impairment rating. And another comparison is when two or more nerve roots are involved on the same side, the largest impairment is rated at 100%. The additional then goes to 50, and then you calculate out by using that 0.6 or 0.4 result. In the AMA, previous, all nerve roots got 100%. We didn't say, well, the L5 is worth 100. If there's an L4, that's only worth 50%. We gave 100% to everybody, and then we calculated out based upon our formula what percent of the 100 they would get on each one. Carpal tunnel took a big hit on the new guides. We used the CTS-6. I don't know how many of you are familiar with the CTS-6 PROMA study to decide what is how significant the carpal tunnel is. So, and then versus the old book, the entrapment neuropathies are rated according to test findings. You had to have a positive EMG or NCV on the carpal tunnel studies, or a surgical procedure. And so we go to the page, we have it down, and we give them a rating. When I first started doing AMA impairment ratings back in 1989, carpal tunnel was rated at 32%. In the 6th edition, it went down to about 12%. Now on this edition, it's like 1 to 2%. And if you can tell me what the differences are here, God bless you, because I don't know. That's how they redid the AMA digital, which is, by the way, getting some blowback from a lot of people, including me, about where they came up with their numbers. So the steps in calculating the digital 6th edition now confirm that the patient's at MMI. This is a big decision you have to make in the AMA guidelines when you do these tests. Because if the patient is at MMI, you then cannot calculate the number. So what defines MMI? So maximum medical improvement is that they've reached a level, they may still have problems, and they may even need palliative treatment. And this comes up on depositions a lot with me, where they'll say, well, Dr. Weiss, are you aware that he's going to have pain management in the next 2 weeks? He's going for epidural blocks. And I'll say, yes, I am. And you still put him at MMI? Yes, I did. Well, how could you do that? I said, it's easy, counselor. Interventional pain management, as good as it is not going to cure herniated disc. I haven't seen one yet. I can be corrected if I'm wrong. I have a lot of good neurosurgeons here that can talk about that. But it's not going to cure. Radiofrequency ablation procedures are not going to cure facet joint arthropathy. So if the patient's not scheduled for surgery, and that's my criteria, then he's at MMI. He's entitled, though, and I always say this in the deposition, he certainly is entitled for the treating physician to recommend interventional pain management. That being said, they're still reach the criteria for MMI. So you have to make that decision first. Then you go to the platform, you click on the right top, you then get to the table, you then decide where you are at the table, you select the appropriate body, and then you give your number, you scroll down till you reach your final number. And that is really how these guidelines have been formulated. So beware that if you haven't learned the 6th yet, learn the 6th edition, and then depending upon where you practice and where your state is, whether or not you're going to go to the digital. Nobody has adapted it yet. The only rumor is that the Texas legislature is going to adapt it. They will be the first state. So if any of you practice in Texas, you may be under that. You may be under that concept.
Okay. I think at this point in our program,